I sit with the Director General of the Ghana AIDS Commission, Dr. Prosper Akamo. A year ago, he was appointed to this office to lead the country's charge against HIV and AIDS to get it closer to the 2030 global target of ending HIV and AIDS as a public health threat. In Ghana, available data shows that over 300,000 Ghanaians are living with HIV. And interestingly, the demographic survey shows that between 2018 and 2022, the use of condom, one of the most effective ways of preventing AIDS or HIV, had dropped. Dr. Akamo, welcome to Joy News.
Thank you very much.
Tell us, when you took office, what were the numbers looking like in terms of HIV prevalence rate in Ghana?
Well, thank you very much for the opportunity. And when I took over the office of the Ghana AIDS Commission, as you rightly said, the task was to make sure that we got to the 2030 global targets of making AIDS not a public health threat. Specifically in Ghana, our figures were not that encouraging. Let me put in perspective that over the years we had made some progress in bringing down the figures substantially. But the typical Ghanaian syndrome, soon as you begin to make progress, you take your eye off the ball. And then we started having resurgence in new infections. And you know, the new infections build the base of the people living with HIV/AIDS. And as you rightly said, the statistics show that in Ghana here, we have over 334,744 people live with HIV/AIDS by our national estimates. That gives us a national prevalence of 1.49%. Yes, though we have come from a prevalence rate of 2.8% in 2010, but we should be bending the curve much more than that, especially if you look at the new infections rates. The new infection figures is about 15,290. And more worrisome with these new infections are the fact that if you take the age group 15 to 24 years old, they alone account for 30.1% of those new infections. That is not good enough, because these are people who are young, who are going to live long with the disease, who are going to have a lot of morbidity. They are the future workforce of the country. And if we don't take time and we don't bend down the curve and reduce infection rates in these people, we're going to have a future generation of people living with HIV, especially in the younger age. Further to the statistics, we also realize that a lot of people are not on treatment. They are diagnosed but not on treatment. If you look at the global targets of reaching 95, 95, 95, that means that once we get to that level, we have reached a target where we can say the epidemic is under control. 95% means that 95% of people living with HIV in the country know their status. 95% of those people who know their status are on treatment. And the third 95% is that 95% of those who are on treatment have reached a virus level where you can detect it in their blood. That is very important.
But the concern also is there may be a lot more people living with the disease without knowing about it.
That is the problem, because if I come to the statistics with respect to that, you would see that the first 95, that is 95% of people who should know their status, we are only doing 68%. So even if you don't take the whole 100% and look at the 95, 68% to 95, about 27% are not in the know of what their status. If you take the second 95, that 95% of those who know their status should be on treatment. That one we are just doing 69%, when we should do 95%. However, those who are on treatment, we have reached 90% of those people who are on treatment currently not having their virus, a virus detectable in their blood. So the most important thing is to get people tested. Once we get that baseline, we have to roll people onto a treatment. Once they get to treatment, we are very sure that they will get to a virus level that will not be detected in their blood. And at that point, if you get that, you can say that you are almost getting to epidemic control.
In terms of testing,
yes,
what is the problem there? Why are we recording such low numbers?
It's just because of the stigma that is associated with the disease. And you, as a journalist, you know that every disease of stigma in Ghana is highly avoided. And many people just fear to go and take an HIV test. But it is important to take an HIV test. First of all, if you know your status, you protect your status. And if you're positive, you roll on to treatment. And let me tell you that those who are on treatment are living their God-given years. As long as you are on treatment, unless anything untoward happens to you, not HIV, not AIDS that will kill you, something else, you may die of something else. So it is important to get to know your status and be on treatment. And therefore, the next line of paradigm of thinking is to ramp up testing, especially making the self-testing available. You and I would know that if you have to go to a hospital setting or a medical setting to test, many people will not go. So we are now ramping up the self-testing mechanisms, that you can come, register, take your self-test kit, go to your house, sit in the comfort of your room or your washroom, hide yourself, test, and these are things you can just roll in your mouth, test it, and know your status. You may grieve over your status for a while, but at a certain point you accept it and then you go for treatment.
Where
that is within the privacy of your own house. Yes.
Where are they supposed to get these?
You can take these self-tests from the antiretroviral treatment centers. You just go and they give them to you, and you don't have to take the test there for your status to be known.
Are they across the country?
They are all. We have over 780 of them across the country. In fact, we are even trying to vamp up more of those centers, making them closer to doorsteps, and even conveniently so, people can just go there and pick those samples.
Do you have these self-test kits available?
We have the self-test kits available. In fact, we within this Valentine period that's coming, it's one of our targets to ramp up the self-testing. So from yesterday, I have distributed over 1,048 boxes. Each box contains about 50 test kits across the whole country to the technical support units of the Ghana AIDS Commission. And this will be deployed across the whole country for people to take up self-testing as part of the Valentine Day celebration. In
December, on the floor of the House of Parliament,
yes,
the first Deputy Minority Whip, Habib Idrisu, made a statement. He was advocating that prospective employees be tested. It should be mandatory for them to get tested for HIV/AIDS before they are employed, and that will help improve the number of tests done so that people can know their statuses, because the problem is a lot of people do not know their statuses. What's your reaction to that?
Let me say that if you look the perspective from which he made the statement, he may have good intentions, but it may have been misconstrued across the public discussion. Let me say that the testing of HIV is governed by law within the Act 938, the Ghana AIDS Commission Act. You cannot force anybody to take a mandatory test of HIV test. It has to be a consensual agreement that the person has agreed to take the test. And the fact that the person has not taken the test cannot be the basis for which you deny him any employment. It's an act, it's in law. Maybe the intention from which the Ghana AIDS Commission saw the Honorable Minority Chief Whip trying to say is the fact that because of our low testing level, if we can find a mechanism across the country which may be acceptable for whereas increased testing, by increasing the testing we can actually know the real prevalence, and we can actually bring people who are having a disease to treatment. That will curb the future spread of the disease. He may have been intending that way, but to mandatorily force somebody that you have to take the test to be able to get a job under the laws of Ghana is not appropriate. In fact, the Ghana AIDS Commission reached out to the Honorable Member to make him know that this is governed by law, and we can't just force people to do that. Get to know that just recently to the military recruitment, there was a false information in the public domain that 60% of those who had gone for the Ghana Armed Forces recruitment had HIV/AIDS. That was a false alarm. It's completely false and not true. The people who have gone for that recruitment training had also signed and agreed that they would take the test as part of the recruitment process before they were allowed to do the test. And that result of 60% is completely false. And you saw the military high command coming out to make a statement that this is not true. And it creates that more social stigma against the disease, which is not right in our culture.
I'm not too old, but when I was growing up in the late 90s and early 2000s, we saw on TV adverts telling people to protect themselves, abstain or use a condom. And that perhaps may have contributed to the low numbers we saw those years. But that's not the same now. You don't hear the adverts anymore on radio or see them on TV or even social media. What's accounting for that? So
you are absolutely right about that. Take 10, 15 years back, almost on every media house, from print media to electronic media, you would see adverts of how to prevent yourself from getting HIV/AIDS and how to protect yourself. You had the ABC, abstinence, be faithful, use condom, take drugs, and then all those we used advocate. But over a period, let's say 10, 15 years, all this died away. No, it's all because of the funding structure of the national response to HIV/AIDS. Much of our funding comes from external sources. And the programmatic outline is based on what the money is coming for. So from the onset, a lot of the money came for prevention because we didn't have the drugs to treat. So we just felt that if people prevented themselves from getting HIV/AIDS, then they would have a low prevalence of the disease. Fast forward along the line, we had very effective drugs. People could take the drugs and live longer. So a lot of the programmatic money went in with purchasing of drugs and other commodities that are related to medications. And therefore, that which was assigned to the prevention became smaller and smaller over the years. And that is how we got these messages slowly dying off the public discourse and making younger generation unable to know what was happening with respect to prevention. So that is the basis of it. So we now need to do a rethinking of the programming, because very soon we are going to go to the next cycle of funding, and we think that the prevention should take center stage. And even then, the previous funding for prevention was only for specific specific categories of people, people they call vulnerable and key populations. That is where the attention was on. But now, the general population is also vulnerable now. Take the general population, people who don't have much of the message are living very reckless lives, sorry to say that. I mean, there are a lot of people who they are serial monogamous. They take the girlfriend today, tomorrow they take another girlfriend, and that is a serial monogamy. That is also as vulnerable as any person who is like a gay or a lesbian or a sex worker or an AGYW, adolescent young girl who cannot bargain for safe sex, you understand, or an intravenous drug user. But the general population is also becoming vulnerable one way or the other because of lifestyle. It's not uncommon to hear people are doing sex parties and all those kind of things. These are vulnerable things that we need to do. And this information of prevention has to get to everybody, not a selected group of people. The general population has to be targeted for prevention. And
I'm thinking the issue even gets worse because the US in September last year also cut funding to AIDS-related programs. Did that affect Ghana?
Absolutely, because the US support for Ghana is, let me just specifically come to Ghana. The US support for Ghana is specifically in certain areas. We have corporate agreement with Ghana Youth Commission that we look at the data collection and all those about the treatment, new infections and all those. But more specifically, the US interventions were in 3 of our regions, the half region, central and western region. You understand? And the western and then a half, central is not part of that. And their withdrawal affected interventions in these areas. And if you know the structure of the US support, where they are operating, and by that directive, you can't have other institutions working there. They have just taken those 3 regions to give the support. So it actually created a little bit of instability in those 3 regions. And mind you, these are very critical regions in terms of the national prevalence. They are the regions where the extractive industry is very high. And if you see where the extractive industry is high, especially Galamsey and other structures, that is where migrant sex workers will go. That's where drug users will go. And these are the risk factors for all those infections. So that aspect of it actually interrupted our national response a little bit.
So these regions, mention them again: Western region,
Western North,
and
Ahafo.
And Ahafo. These 3 regions.
Yes.
These are the regions.
So they call them the PEPFAR regions.
Okay.
So PEPFAR is Presidential emergency plan for AIDS relief. You understand? And
Are
it's
these
instituted by the
regions-
U.S. government. President George Bush instituted it, and then it has been support to areas, most countries across the world.
Are these regions the regions with the high prevalence rate?
For the highest prevalence rates is Bono.
Bono region.
Yes, that has 2.22%. The national prevalence is 1.49. Bono region has 2.2. They are the highest prevalence. But you know, the prevalence is the number of people who have the disease over the population. But in terms of absolute numbers, Greater Accra and Ashanti have the big numbers.
Right.
Yes, but because though the big numbers are in Greater Accra and Ashanti, the Greater Accra population makes it have a lower prevalence. But the absolute numbers, they have huge numbers in the Greater Accra.
So the U.S. was helping Western, North,
Western, North,
Western, and a half.
Yes.
After they cut funding,
Yes.
what happened? So now you don't have any support for these regions that they selected initially?
Fortunately, they had cut the support, but later on they gave an emergency period within which they can work. Now going forward, we need to cover for interventions in those regions. And that's where the technical support unit of Ghana AIDS Commission will take over those activities there. But we need to get other civil society organizations that they worked with to be able to work there. In the meantime, there is a window of relief for the organization the U.S. government were supporting to keep the work going on there. Going forward, they are trying to sign a country-level agreement with Ghana for those interventions. The MOU has come out, but we are reshaping it to meet the national needs. Eventually, when we get those ones reshaped properly, then we can have an agreement for support in those areas as well. Know that the U.S. government is also the other donors to the national response is the Global Fund. The Global Fund is the institution that manages the global intervention for malaria, TB, and HIV. So they also receive funds and support country level. The U.S. government supports the Global Fund up to about 40% to 45% of funding. And as they are withdrawing from that aspect too, the overall funding is also going to come down as well. Know that the U.S. government also supports the UN system and the WHO and other institutions like the UNAIDS. And as they are also withdrawing the funds, it also affects these organizations that are also supporting HIV responses in other countries, in the global response. So their withdrawal is quite significant. And I think most countries, they've started having country-to-country agreement to see how they can support.
Would you then say that your operations were heavily dependent on the U.S., such that their withdrawal or their cutback has affected the Commission?
No, they were not completely heavily dependent. The systems they were supporting were linkage to treatment, keeping people on treatment, using community-based systems to link people to treatment. Sometimes people may not just have the desire to get up to go for treatment. You understand?
Even
so
when they know that
when they know their status, yes. So they had built community systems to support all that. So there were community champions that were able to link people to treatment, keep them on treatment. Because sometimes when people take the medications, when they get their sickness and they're going to get into AIDS level, they start getting leaner, they go to hospital, they get the medication, they start getting well. They even look nicer and plumpier than even we those who may not have the disease. And then they think, oh, I'm fine, why should I take the medications again? And may not have the desire to go back to take the medications. They were linking up those ones, and especially other services of the treatment, stigma issues, building communities' resilience and strength to keep people on treatment. Know that the medications for treatment are supported by the Global Fund, which was still supporting Ghana, and with co-funding from the government of Ghana. So get to understand that the Global Fund will give us money, but Ghana will co-fund it so that we buy the medications for the patients to use. So that support was also going on. Remember,
so the medication is free?
Remember, yes,
right,
that when the U.S. withdrew the funding, the President of the Republic called emergency meeting to the flags. When we went, we had to give him the exact nature of the withdrawal. And he had ordered the finance minister to make sure that all funding gaps were covered by that. So through the National Health Insurance and the uncapping of National Health Insurance, a lot of money was released to cover for the activities of the withdrawal.
Okay.
And that was why we didn't have so much instability within the period of the withdrawal. Yes.
The medication is free?
Medication is absolutely free.
Absolutely free?
Absolutely free.
And people can get access to the medication in all facilities?
In all facilities. So we have over, as I said, 748 antiretroviral treatment centers. There are other specialized centers too that you can also go to. There are private and other centers you can go. But wherever you go, it's always free. Yes.
So currently, in terms of funding, you would say that overall, you are getting your funds from the Global Fund and the government of Ghana?
Yes.
Or there are other donors?
There are other donors. UNAIDS, United Nations AIDS Foundation. And then, as I said, the U.S. government were also through USAID. But 2 other cooperative agreements, they are also having country-level agreement. However, let me put in perspective that all the foreign donors, over the period, we've realized that there has been gradual decline. And we have been looking at the fact that one day there will be donor fatigue, and we must prepare ourselves to take over our national response. So the government of the day, John Mahama, has tasked us to look at sustainability mechanisms. In fact, that was enhanced by the African Sovereignty Conference that he had in Accra here. Talked about taking sovereignty of our own needs, including health. For health sovereignty was one of the main things that he spoke about. So we've developed a roadmap of national sustainability, what we should do in case all this funding comes to a sudden halt. So we finished the first part A of it, the route, how to integrate our services into our already existing health structure. And we've had discussions in that part of the roadmap. In fact, we've actually launched it. And we've had the discussions with the National Health Insurance Scheme, because we can actually integrate all these services into the National Health Insurance Scheme. So that all the drugs and everything are purchased for that. We've also realized that much of our counterpart funding and much of the money that the Global Fund is giving for treatment, about 68 to 70% of the money goes to buying medications. So we have also undertaken a study to look at the feasibility of local industries, producing local pharmaceutical industries, producing the medications in the country here. We finished that feasibility studies, and right now we have 2 companies that, if they are given the opportunity and the necessary arrangements, should be able to produce those medications for us. Why would Ghana government put a counterpart funding of, let's say, almost $40-something million, or $50 or $60 million, $80 million to purchase medication outside, when we can support the local industry as part of that? And the president's manifesto, the NDC's manifesto, to look at the fact that building of local pharmaceutical industries is a hope for us to gain that sovereignty in our health sector. If we dovetail our sustainability mechanism into that, it would support the national effort in building resilience and sustainability. So we have done that with the National Health Insurance Scheme.
From the time you took office till now, have you done any studies to look at the prevalence rate? Because we know that somewhere in 2024, that's when we recorded over 300,000 people with the people living with HIV. Have you done any survey like that?
The studies to get a new, it's a continuous study. It's not a one-time. So we have the mechanisms across the whole country, collecting data for new infections. So on a dashboard, in fact, we have what they call an e-track. On a dashboard, you can see what are the new infections that are coming. Currently, as we speak, the National Estimates team is at the Cathedral, and they're taking a conference. They are looking at how we can now aggregate all that data into bringing out the new estimates for 2025. So, of all the processes of collecting the data, from sentinel surveys, from pregnant women, from testing kids who are newly born, from self-testing, from all the aggregated data, we will look at the new infection. We also look at those who are on treatment. We also look at those whom we've been able to prevent from mother-to-child transmissions. And we also look at other aspects of the national statistics as well. So within, let's say, by April, we should get the estimates that we've been able to do for 2025 to reflect the work that has been done since a year ago.
John, you did a vox pop of Ghanaians, whether they use condoms. And what we heard predominantly was that people are not using condoms. 13th February is slated as the International Condoms Day.
Yeah.
And this is the first time Ghana is commemorating that day. And the 14th of February as well, Valentine's Day. Why do you think people are not so much interested in using condoms, and what would you say to them?
If you follow the Ghana Demographic Health Survey, and the estimation of the use of condoms is very low, very abysmal. And that is not good enough for a country. There are various reasons why many people don't use condoms, you know. And first of all, the fact that people say they want intimacy, direct contact. And people have also said that our condom, in fact, we have taken a survey of people's perceptions of the free condoms that we distribute. Ghanaians say they are too thick, they don't give you sensitivity, so we are putting all that together. And very soon we'll come out with a national condom strategy.
Okay.
National condom and lubricant strategy, which will now look at all the information we've gathered across the country about people's perception about the use of condom, so that we can refashion the kind of condoms we are doing to meet people's needs. Maybe what we are providing is not what they want. We are also doing that study alongside the use of other condoms that are not under our program. Like people would go to pharmacy and buy the type of condom. We're taking all the statistics together to see whether there's a preferential direction where we should go, and the reason for that preferential direction, so that we can prepare our national condom strategy properly. Yes, but some of the reasons people will not use is the fact that they want direct intimacy. And of course, if you look at the use of condom, if people have intimate relationship for, let's say, about a week, they may use a condom for a week, and by the third week, they've stopped using condoms. They get used to each other, and that is how it goes with Ghana. And the other thing is that the female condom, we had a little bit of problem with the female condom. It ran out of the system. In fact, one of the biggest requests we get is the female condom. First of all, the first one was inappropriate for our Ghanaian environment. The second one, the second set, after taking the national information about how to manage the female condom, we got a newer set which was more acceptable now. But of course, there had been issues of items that are locked up in the pot that we've not been able to clear. We're trying to get those ones sorted out. But it is, if we need to vamp up our condom use, the next condom strategy will look at the reasons why we are not, men are not using condom that well and properly, so that we can also develop and get condoms that are more friendly to the Ghanaian use. You get to know that there were some times that there were condoms in the system. They said they were smaller for Ghanaian men, and that they were besting because I know Ghanaian men are quite in doubt in one way or the other. So we'll leave it like that.
So you'll be sharing condoms on the 13th of February?
Yes.
Yes. Tell us about this free condom.
Okay.
Does it meet the needs of Ghanaians? 13th
of February has always been World Condom Day. And in fact, for the first time, Ghana will be observing it. Ghana AIDS Commission is leading this together with the AIDS Health Foundation, who are now entering Ghana for the first time. So we'll launch it on the 13th of February. And this is where we bring the awareness to the use of condoms. It's part of the strategy to make sure people get to know that, look, there's International Condoms Day, and let's use condoms, and we can get the public awareness about condoms. Secondly, we'll be doing condom distribution of all types of condoms, and people can have access to the condoms on the distribution day. But more importantly, it dovetails to the Valentine Day.
How many condoms will you be distributing?
There will be various types that will be there, flavored, non-flavored, and all those kind of condoms.
Okay.
So we target to distribute
across
as much
the country.
Across the country. And as I said, in sending the HIV self-test to the regions, I also send some condoms to each of the regions. Yes.
Right.
So it is to prelude the Valentine's Day. Because
please turn to my camera and then speak to Ghanaians about the Valentine's Day and how they need to protect themselves.
Valentine's Day, a wonderful day of the year for us to share love, affection, and be with our loved ones. It's a day of love, sharing, chocolates, love messages, gifts, flowers, teddy bears, whatever, even giving our hearts out. But it also leads to intimacy. And in our excitement about sharing in our love, we need to be careful about how much intimate we get to ourselves. We need to take responsible decisions about our intimacy and protect our lives. Wear a condom. If you are stay faithful to your partner, or if you are not faithful, please wear a condom to protect your partner. Let's enjoy this beautiful day, this fantastic day of the year, sharing our chocolates, our heart-giving affections, our minds, our souls, our energies, but let us use condom. Yes.
Thank you so much. Dr. Prosper Akamor is the Director General of the Ghana AIDS Commission. Thank you for watching. My name is Gemma Appiah.